I am your host, Dr. June Ruiz, a gastroenterologist, a medical author, and advocate. We will be journeying with you on this path to healing hemorrhoids. Tonight, I am joined by two renowned medical and surgical experts who will share in our deep dive discussion on hemorrhoids, its diverse clinical presentations, and the right choice for treatment. Hemorrhoids in Tagalog is called almoranas. The other terms for this condition are rectal lumps, piles, and voids. But what are hemorrhoids? Tonight, we will be discussing essential medical information on hemorrhoids that we can apply in our clinical practice. Joining us first is our main resource person, a gastroenterologist, the Assistant Division Chief of Gastroenterology of the UPPGH, former President of the Philippine Society of Digestive Endoscopy, Dr. Mark Anthony De Luso. He will be sharing with us some clinical pearls on hemorrhoids and its management. Welcome, Dr. Kitts.
It's great to be here, June.
It's an honor to have you here.
Well, it's a great pleasure to be discussing with you a very common topic. Let's shed some light on this very ubiquitous enigma of our behinds.
Okay, Dr. Kitts, let us proceed. For starters, what are hemorrhoids? What are its causes? And how do they arise? Is this a common condition among our patients?
All right, hemorrhoids are very common. They affect up to 39% of the population. These are dilated veins arising from superior and inferior hemorrhoidal veins and are confined to the submucosal layer of our rectum. They are particularly common in pregnant women and patients who are older than 50 years old. They are basically caused by increased pressure in these aforementioned veins via mechanisms such as constipation, straining, lifting weights, obstruction to the outflow of these vessels, and even just sitting for prolonged periods of time.
What are the common complaints of patients who suffer from hemorrhoids? How can we differentiate hemorrhoids from other causes of complaints like rectal bleeding and pain?
So there are basically four common symptoms related to hemorrhoids. One is anal pruritus or itching, second is bleeding, third is pain, and fourth, rectal prolapse. Bleeding is the most common. It may be differentiated from other causes of bleeding as it usually presents as bleeding after a bowel movement, described as dripping blood after a bout of hard stools, or just plain streak of blood on toilet paper after you wipe. Pain is usually caused by thrombosis of these enlarged veins, and there are usually bluish areas in these palpable hemorrhoids. And they may cause patients to have difficulty sitting down due to the pain.
As clinicians, we know that hemorrhoids can be classified as internal and external. How can these two types be differentiated from one another? Can you also review us on how internal hemorrhoids can be divided further into different grades?
Internal and external hemorrhoids are differentiated from each other by topographic location, meaning internal hemorrhoids are located above and the dentate line, and thus are located in the rectum and tend to be non-painful because of the visceral innervation. External hemorrhoids, on the other hand, are located below the dentate line, thus the skin, and thus have an epithelial lining sensitive to pain because of its somatic sensory innervation. Internal hemorrhoids are further classified into four grades, with each grade having different treatment modalities applicable. So let's start with grade 1. Grade 1 are just engorged vessels that do not prolapse outside into the anal verge, so that they're just confined to the inner. Grade 2 are internal hemorrhoids that prolapse on straining or bearing down, but they spontaneously reduce or go back inside. Grade 3 prolapse and need to be manually reduced to return back inside the rectum. Finally, at the end of the grading, grade 4 internal hemorrhoids are prolapse and cannot be reduced or brought back into the rectum anymore.
Hemorrhoids are managed differently depending on its severity and presentation. Dr. Kitts, let us start with different clinical scenarios and how do we manage each patient. Let us meet JC. He is a 25-year-old Filipino male who works as an IT engineer in one of the big companies in Makati. He has been seeing small streaks of bright red blood on top of his stools and also on the toilet paper 3 times in the last 2 weeks. He denies any abdominal pain or perianal pain. His diet is usually composed of fast foods as he lives by himself and he considers his job as a very stressful occupation. He's into beverages like soft drinks, coffee, milk, and iced tea. As he works on his desk most of the days, he has not had time to exercise. He has no medical illness, no family history of colon cancer. Because of his fear and concern for this amount of rectal bleeding, we went to see you for a consultation of his condition. He wants to find out if this is from hemorrhoids. How would you suggest approaching the management for this patient?
Good question, June. So, as with all patients, we should always begin with a complete history and thorough physical examination, including a digital rectal exam. But most patients don't like that, but we have to do it. Most likely, this patient has internal hemorrhoids that will be just grade 1 or grade 2. The initial management for these cases is recommending a high-fiber diet and increasing the fluid intake, with the avoidance of straining and prolonged sitting to reduce pressures in these patients' hemorrhoids. Stool softeners may also be given if he reports hard stools to lessen straining during the episode of defecation. Lifestyle modification is key in these cases, and thus replacing his sedentary fast food lifestyle to an active, high-fiber one will benefit him tremendously. Sometimes hot sitz baths may improve his symptoms, particularly if he has some anal irritation or pruritus.
A great discussion, kids. Let us now go to our second patient. RL, a 52-year-old male banker, came into the clinic for a checkup due to intermittent rectal bleeding and occasional pain in the perianal area with prolonged sitting. He reports long-standing constipation and tends to linger in the toilet during bowel movements with straining due to constipation. He does not have any abdominal pain, weight loss, or fever. He does not smoke or drink alcoholic beverages, but is fond of eating steaks every week. He has tried over-the-counter ointments and fiber supplements that only temporarily gave relief. On examination, palpable and visible engorged vessels were noted in the anus, which can still be manually reduced. There were no signs of thrombosis, but the examining finger does show some streaks of fresh blood. Let's start with a few questions. What would be your clinical approach to this patient? What are the other diagnostic tests would you recommend, like a colonoscopy would be indicated here? Do we still try conservative management or proceed with procedures like rubber band ligation or even surgery?
Okay, so those are very important questions for a very common patient. As with all patients with hemorrhoids, lifestyle modification should always be advised, particularly changing to a high-fiber diet, as I mentioned earlier, with lots of fluid intake. Medications such as phlebotomics have been shown to reduce bleeding and anal irritation in these instances, and thus can be prescribed as well, especially in this patient. Hot sitz baths and stool softeners should always be given to further improve the patient's symptoms. But remember that a colonoscopy is highly recommended in this case because of the patient's age and presenting sign of bleeding. These two alone can increase our suspicion of a possible colonic malignancy or even a colonic new growth, not just hemorrhoids. I usually still pursue a conservative management in this case with the above-mentioned maneuvers, and if these do not improve the patient's problems, probably 2 to 4 weeks of observation, I would then recommend band ligation before doing surgery.
So in this patient, which is better in this case, a band ligation or surgery? And if the patient underwent surgery, what is the chance that the hemorrhoids will return again?
Again, a very important question. In this particular patient, since patient is a grade 2-3 patient, surgery and band ligation are both logical choices. And it just boils down to the patient's preference, as both have similar outcomes. Band ligation may be more cost-effective though, in terms of its costs.
As medical management is preferred over surgery, let us discuss the use of diosmine and hesperidine in patients with symptomatic hemorrhoids. What is the evidence on the efficacy of diosmine and hesperidine combo in symptomatic hemorrhoids?
Well, diosmine and hesperidine belongs to drugs called phlebotomics. They improve venous tone and microvascular permeability, thus preventing bleeding from hemorrhoids. And they also heal damage from these venous vessels. A Cochrane study of 24 randomized controlled trials have shown that it really improves outcomes, like bleeding and pruritus, but not pain. Recent studies, however, which were not included in this Cochrane study, also echo the same results, with a few even showing improvement in the pain scores. Furthermore, most studies have shown no serious side effects with the use of these compounds in the treatment of hemorrhoids.
Thank you, Dr. Kitts, for your insights. I'm sure our viewers and listeners are all engaged in a rich conversation right now. I will see you later during a Q&A session. We have learned from Dr. Kitts so much knowledge on the medical management of hemorrhoids, but we are still up for more. Dear viewers and listeners, as I have promised tonight. For our next case, our resource speaker is a prominent colorectal surgeon and the current training officer of the Division of Colorectal Surgery of the UPPGH to give us more insights on our discussions in this podcast. Let us all welcome Dr. Mac Onglao. Hi Doc, kumusta?
Hi Doc Jude, I have never been better. I'm so thankful that the pandemic is not as virulent as it was 2 years ago. At least now we have some sense of normalcy in our daily lives. But you know, Doc June, there are still some cases that need to be talked about and treated, which have been existing in our lives way before the COVID-19 pandemic. I'm talking about hemorrhoids. And I'm sure you and our listeners have been engaged in already since the start of this episode.
I agree, Doc Mac. Thank you for joining us. We have been having discussions to raise more awareness on hemorrhoids and the clinical practices that we can do for its treatment. We will now go to our third case. MJ is a 44-year-old male professor who came into the emergency room for severe anal pain. He has a 2-year history of grade 3 hemorrhoids, which he wasn't able to seek treatment during the pandemic. He has no comorbidities. On physical exam, you see this: edematous, strangulated piles at the right posterior and left anterior, non-reducible and very tender on palpation. How would you approach the management of this patient, Dr. Mac?
Sure, Doc June. Let's talk about this case. He is a 44-year-old male who came to the emergency room for severe pain. This is a classic case of thrombosed hemorrhoids. For these cases, we have what we call the golden period, which is thrombosis presenting within 48 to 72 hours from the onset of pain. Patients within this time period are at the height of their pain, and they would benefit greatly from surgical removal. On the other hand, patients presenting after 72 hours would feel that the pain is progressively decreasing. Doing surgery in these cases would often cause more pain and complications. These cases may be offered conservative management, which would include lifestyle modification, pain medications, and a diosmine and hesperidine combo.
How do you decide which patients will need surgery even after the golden period?
We evaluate this based on clinical parameters. Grossly, if the hemorrhoids have signs of gangrene, or if the patients appear septic, we will push for surgical removal, even after the golden period has passed.
Dr. Mac, how would you advise patients who undergo the conservative approach?
We expect gradual improvement of their symptoms over the next few days. Perianal pain should decrease, and the thrombosis and edema of the hemorrhoids should subside. We usually recommend an elective hemorrhoidectomy for them after 2 to 4 weeks of conservative management. In some cases, we even see dramatic resolution of their symptoms, wherein surgery is no longer required.
Thank you, Dr. Mac. What are the surgical options for this patient?
In the emergency setting such as this, in acutely thrombosed hemorrhoids, the best option would still be surgical excision. Newer techniques would employ advanced energy devices, which will only help in the hemostasis. However, for elective hemorrhoidectomies, we have more options available. This would include stapled hemorrhoidopexy, Doppler-guided hemorrhoidal artery ligation. A surgeon must be well versed in deciding which is the best option given a patient's clinical presentation.
What are the post-operative expectations and possible complications?
To be honest, surgical excision of hemorrhoids is very, very painful. The pain often lasts for 1 to 2 weeks after surgery, and we often prescribe 2 analgesics just to control the pain. It is important to advise these patients well regarding this so that they can manage their expectations. Otherwise, they will be calling you every day complaining of the pain. Complications would include bleeding and stricture, both of which can be avoided with proper surgical technique.
Thank you very much, Dr. Mack. I will see you and Dr. Kitts for the Q&A session in a bit. Hello again, everyone. Good evening. I hope you enjoyed your food, and I hope you also learned something from our discussion earlier. You are still with me, Dr. June Ruiz, journeying on this path to healing hemorrhoids. So before the break, we had our discussion with 2 prominent resource persons, Dr. Kitts and Dr. Mack, and we were able to get a lot of clinical pearls from our case-oriented scenarios. So I am bringing back our 2 guests, Dr. Mack and Dr. Kitts. Hello.
Hi, Dr. June, Dr. Mack. Good evening, everyone. Nice to meet you again after a long time.
Good evening, everyone. Hi, Dr. June. Hi, Dr. Kitts.
So it is a pleasure to have the 2 of you with us, and this is our Q&A. So for those, in our audience, you could type in the chat box to type your question, and for those in the venues, we will have 2 roving mic persons that you could approach them, you could introduce yourself, and you could ask your question live. So let's go to our first question. This first question is for Dr. Kitts. Traditionally, we have internal hemorrhoids and external hemorrhoids. However, there are also mixed hemorrhoids.
Yes.
So how do they usually present, and how can you differentiate them on exam? Dr. Kitts?
All right. So I think Dr. Mack would agree with me that to really diagnose a mixed hemorrhoids patient, you have to take a look because you have to see where the dentate line is and to see if the hemorrhoids are above and below. And you should see both. In terms of presentation, they would present exactly the same as your internal and external hemorrhoids, with the exception that external hemorrhoids would present as pain more than bleeding, and internal hemorrhoids would just present as painless bleeding. So it's a mix and match, but basically visual inspection is the key. So you'll know it's mixed hemorrhoids.
Okay. For our next question, this question is for Dr. Mack. There are other anorectal conditions that can also present with rectal bleeding, itchiness, and other complaints. And some of these conditions could be like fistula, perianal fissure, it could be an abscess, or even anal warts. How can we differentiate them in terms of clinical presentation and on exam?
Thank
Dr.
you,
Mack?
Dr. June. Actually, the differentials for hemorrhoids are very varied. Fistula, abscess, warts, all of these are very different disease entities. The good thing with anal conditions, usually with a good history and a good clinical exam, meaning looking at the anus, doing a good rectal exam, you'll be able to differentiate all these disease entities. And you should always rule out cancer for these patients who present with rectal bleeding.
Are there any specific characteristics as far as for each of those conditions that you described?
Yeah. For cancer, do a good rectal examination. Usually, you can palpate a mass. For fistulas and abscesses, there's an area of inflammation and erythema in the anus. For warts, you can see papillomatous lesions. And for a fissure, usually you can just see the external skin tag. But you'll know right away because the presenting symptom of the patient is severe anal pain and like a tearing sensation. So for fissure, don't do a rectal exam.
I agree. I agree. So basically, as you were saying, the clinical presentation from the history may be similar, but it is on exam, on visual inspection, that you can actually differentiate one from the other. Thank you, Dr. Mack. So if, for those people here, feel free to approach our roving mic person so you can ask your questions directly and live to our speakers. Our next question is for Dr. Kitts. You have comprehensively discussed the advantages of using diosmine and hesperidine on the treatment of hemorrhoids. However, in clinical practice, I think we need to find out what would be the key features on history, on exam, that you would say, I think it's time to start this combo, or I would just go with fiber supplements and stool softeners. So what would be the key features on exam and on history that we can educate and help our audience here?
Okay, very good question because people will ask after this conference. Basically, if you look at the evidence, as with the Cochrane study I mentioned, if you have bleeding and you have anal pruritus or any irritation in your anus, then it's already indicated to give your Dioxel, because it really gives you better outcomes in terms of decreasing the bleeding and decreasing the pruritus. And most of our hemorrhoid patients actually bleed anyway. So most of your patients would benefit from being given these medications. But don't forget about fiber and increasing fluid intake, because that's a mainstay. And if you add this medication, I think the outcomes would really be better in terms of everything.
So you would say once the patient presents with significant amount of bleeding,
Yes.
they should be started
Yes.
on the diosmine and hesperidine. Any additional thoughts, Dr. Mack?
I was talking to Dr. Kitts a while ago. Remember, we showed the very severe thrombosed hemorrhoids. And that's why I emphasize the golden period, because some patients who present 72 hours after, usually you can just treat them with a combination of conservative management, lifestyle modification, and a phlebotomic. And what we see is after a few weeks, the thrombosed hemorrhoids really do resolve, and some of them won't even need a surgical intervention.
Yeah, I was telling him nawawalan siya ng kita.
Okay, that's correct.
Yeah.
That's correct. Let me just, I guess, key back to one of to the answer of Dr. Keys. As you said, with bleeding, you may probably start with the combo.
Yeah.
Is there anything to quantify the bleeding? Let's say if the patient actually presented to you, let's say, on day 2, and the bleeding had already resolved on the first day, and you did an exam, nothing very, concerning. Would you still continue to start the patient on the combo and give it for like a 1 to 2 week course? Because I think this is one of a key scenario that we see in practice.
Again, a very good question. Once you have a history of bleeding, I would still recommend giving your phlebotomics because they would recur. So might as well treat them as they are actively bleeding. And once you give the medication, there are even small studies, actually there are large studies now, RCTs, that show when you give a patient who had a history of bleeding but not active bleeding, given phlebotomics, they actually improve in terms of decreasing the recurrence of the bleeding and the amount of bleeding. So it's still useful.
And would you give that prescribed regimen, which is if you have 500 milligrams tablets, 4 tablets for the first 4 days, and then 3 tablets, I think it's 6 tablets, 6 tablets for the first 4 days, and then the 4 tablets for the next 3 days, and then 2 tablets for another week. Will you give that regimen for all comers, or I would try to modify
Yeah.
because I know it's
Yeah.
a little bit costly too for
Yeah.
each tablet.
Well,
or-
honestly, I modify because those studies are based largely on the weight of the patient because if you're larger, you have larger veins. So that's why they give a lot of medications in the first week because they would actually help in decreasing the bleeding. But in terms of giving them like box like 643 as you mentioned, I usually use them in patients who are more than 60 kilograms, especially if it's an acute attack of hemorrhoidal bleeding, etc. But if it's an intermittent bleed or a past history of bleed, I would actually use the lower dose of just 3 tablets per day for a week.
Okay. Dr. Mac, do you have anything to
Same.
add as far as your use of phlebotomics in your anorectal patients?
I use the same regimen as Dr. Delusong. If the patient presented acutely, like in the emergency room with an acute hemorrhoidal attack, I use the 6443. But if the patient comes to your clinic, no thrombosed hemorrhoids, no active bleeding, but had a history of hemorrhoids, I'll use a lower dose. Sometimes 3 times a day, sometimes 500 twice a day.
Do you have any patients that you actually would end up? I know sometimes the manufacturer's recommendation is to use the 2 tablets per day for a relatively longer period of time. Have you tried that in your patients?
Yeah, of course. Initially, you should use the recommended dosage. But as you go about your experience with your practice, then you adjust. Just like what I did with my patients, because there are really small patients. I think that giving too much is overkill, in my opinion. So I give a lower dose. Yeah.
Thank you. Anything to add?
For me, Doc, I offer 2 to 4 weeks of the
4
conservative
weeks.
management. If the patient still has significant bleeding, prolapse, or symptoms, then I'd offer surgery.
Okay.
Para may kita naman.
Yeah, okay, that's great.
Sayang
Yeah.
naman.
Yeah.
Okay. So we actually have a question from table 10. So if we can have that person introduce themselves and then let us know who do you want to address the question to.
Hi, good evening. This is Mitch. Thank you. I'm enjoying the podcast, by the way.
Mitch.
So for kids, my question is: so you do rubber band ligation. Which one do you use, the CRH Oregon or the Olympus? And then have you tried also other appliances that uses cold therapy instead of hot sits bath? And for the surgeon, does it matter if we refer them to you to indicate which piles are involved? And then if I'm a lady and refer them to surgery, they're going to be expecting to be positioned, awkwardly, just like it used to be while doing your hemorrhoid. That's all. Thank you.
Dr. Kiss, you want to start?
Okay, so the first question is which rubber band ligator device do I use? Before I was using the Oregon because it's available. But nowadays, I use the usual RBL that we use for esophageal varices. So I use a gastroscope and then I retroflex in the rectum and then I band them. It's actually much easier for me because we're trained to ligate esophageal varices and the technique is the same. Okay. And the second question is,
Of the appliance using cold therapy.
oh yeah. So there are studies on cryotherapy and even the cold sits bath, but the evidence is not that robust yet. The hot sits bath has a lot of evidence for it, and I would recommend using that first. But it has the cold therapy, including cryotherapy for varices. It has been gaining momentum recently because of the it's a probe that it's like you blow liquid nitrogen so that you will freeze the veins of your hemorrhoids and it will thrombose and close up just like what we do for glue injection or rubber band ligation. It will stop the growth or the explosion of the veins. But again, the evidence is still not that robust, so I would recommend not using it yet. Not yet.
Dr. Mac, I think for the question of Dr.
For the first question was, will it help us if you identify which piles are symptomatic? So for that, it's very helpful for us because usually we know that the hemorrhoidal pillars are normal parts of the anal canal. And as good surgeons, we don't remove all these piles all at once because we know the complications of excessive hemorrhoidectomy are stenosis, stricture, severe pain. So for surgeons, we just treat the symptomatic pile. And if you can help us tell us which one is the most symptomatic for the patient, it will be very helpful. Otherwise, kasi ma'am, what we do when we do the examination under anesthesia, we'll just usually locate which is the biggest pile, and that's the one which we will remove. And for the second question, in my practice, ma'am, I rarely ask patients na tumuwad. Kasi nga, it's a very uncomfortable position. Especially kung nagki-clinic ako na I'm a man and mag-isa lang ako. So usually, I ask them to do the left lateral decubitus position na they're facing away and have a blanket over them para medyo mas relax sila. And also, always ask for consent kung okay lang sa kanila to have the examination done.
So even for surgery, you do a left lateral position, not anymore the Jackson front.
For surgery, it depends on actually the advantage of the jackknife position. It's just, we have more space. There's an assist, may intern pwedeng manood. Pero sometimes, like in some hospitals, it's easier actually to just have them in the lithotomy position.
Yeah.
Pero yun lang, mag-isa ka lang doon kasi nandun yung legs eh. Pero usually naman ma'am, they're asleep and sedated. Kaya whichever position is best for the surgery you're planning, that's what we do.
Thank you, Dr. Mitch, for your question. Maybe I have a follow-up for Dr. Kitts. When you actually do the rubber band ligation using the endoscopic direct visualization approach, have you heard of any potential complications?
I've had a lot of complications. So my tip for you guys is never do rubber band ligation near or at the dentate line because your patient will curse you because it's very painful. So my rule of thumb is I do rubber band ligation 1 centimeter and above of the dentate line so that you will be away from the somatic sensory nervation of the skin so that you will have no pain. And then the other complication is you can actually have immediate bleeding. Just like your esophageal varices. You can ligate it, but it will explode. So that's a risk. But you have to explain to the patient that it can happen. Other things that can happen is post-ligation bleeding. So when you ligate it, there will be an ulcer, and that ulcer can bleed again. And of course, infection, because you're creating ischemia. And this is the rectum. So sometimes, not always, I give antibiotic prophylaxis.
Okay. I think we have a question here from Ash, who is a Zoom attendee. And she says, good evening. Thank you for the informative talk, doctors. I have a question for Dr. Delusong. What is the safety of using phlebotomics in patients with recent acute coronary syndrome or coronary artery disease for that matter? Can we use them safely in these patients?
Okay, malas naman, no? Nag-MI na, tapos nag-almoranas pa. So, remember the pathophysical mechanism of action of phlebotomics is mostly for veins and CAD is arteries. So the effect is very minimal. You can actually use it safely. But the evidence, of course, is not many. Because who studies MI and hemorrhoids at the same time? So konti lang. And most of the side effects are just plain and simple gastric upset, nausea, vomiting, etc., diarrhea. And no reports of increased episodes of heart problems or even MIs. So I think it's safe still.
Okay. So our next question is actually for Dr. Umlao. Is there a role for post-operative use of phlebotomics? From Ash, same person.
Hi, Ash. Ash is my good friend.
Okay. Hello, Ash.
Yeah. Actually, although the studies are mostly for acute hemorrhoidal attacks, we've started adopting the use of phlebotomics for the post-operative period. we find that it reduces post-operative bleeding, it reduces post-operative pain. So definitely it has a role, although we need more studies to support this practice.
Okay, thank you. We have another question for recurrent disease. So talking about grade
Grade 2, yeah.
blood streak stools, good dietary and toilet habits, no clinic procedures available. What is the next step? Do you repeat the regimen of phlebotomics? For how long and how often? I guess the person is asking, this is a repeated episode of bleeding after taking phlebotomics. What would you do at this point when there are no clinical procedures available? I think that is the root of the question. Dr. Kitts, any thoughts?
That's actually one of the indications to do endoscopic or surgical treatment already because it's recurrent disease. Kawawa naman yung pasyente. So if it's recurrent disease, then if it's grade 2, I would recommend rubber band ligation. If rubber band ligation is not available, then that would be a problem because all you can do is actually repeat everything. If it's not available in their region, I would recommend the patient to go to an area that has rubber band ligation or even surgery.
Any thoughts?
Same. Yeah. So if your conservative management is not working, it's time to do an intervention. It's either rubber band or surgery.
So basically, you give a patient one chance to get
Sometimes
better.
I give them 2 chances.
Okay. Okay, next question is from Dr. Abigail Taruk from Cagayan de Oro. So we have somebody asking from Cagayan de Oro. Can the combo of the diosmine and hesperidine be given as maintenance to prevent hemorrhoidal attacks? I think we kind of mentioned this a little bit earlier. Dr. Kitts, maybe you want to give more details.
So if Dr. Abigail is asking that question, that means the patient has repeated attacks already. Then probably she might need to think of other options already, like rubber band ligation again or surgery. Because phlebotomics actually have a bit of tachyphylaxis. So as you've used them longer and longer, their effects actually decrease. Second, the side effects increase because you're using them for a longer time. So again, I would recommend intervention in this case.
Okay.
Maybe more than that, Dr. June, is focus more on the lifestyle modifications rather than just giving maintenance phlebotomics.
Yeah, good point.
Okay. We have a question from table 14. Please identify yourself.
Hi, good evening. I'm Dr. Luis. I'm just wondering if have you used the monotherapy for hemorrhoid, the oral meds that you are mentioning, and other medications like other topical anti-hemorrhoids, like others?
Okay.
So
Crickets.
I guess what I'm getting is because this is diosmin and hesperidine. So you're thinking na pag hiniwalay sila, can you use that? And then the other question is if you add topical medications, is that your question?
Yeah, the second one, doctor.
Okay.
I'm asking if you have used both oral and topical at the same time.
Combination.
Okay, of course. So it really depends on the presenting symptom of your patient. If your patient is complaining of, like, for example, anal pruritus and a lot of pain and bleeding. So, kumbaga, lahat na ng symptoms mo meron. Sometimes one medication might not be enough. So, you can give your phlebotonic and then you can give your ointment because some ointments actually have anesthesia, di ba? And they really help a lot in our patients' pain and even pruritus. So, I usually give combination in cases of more symptomatic patients. But if it's a plain and simple pruritus, sometimes I just use ointment or just phlebotonic. Or if it's just bleeding, then phlebotonic lang. Kasi ang ointment, usually they don't work that well with bleeding. Only phlebotonics.
Just a question maybe on bleeding. You think, can tranexamic acid kind of help with the bleeding? Or...
Favorite natin yan. Ano? So, well, siguro alam nyo naman lahat ang evidence medyo weak for tranexamic acid. But we always use it. I think it's because of our experience that we really see that there's decrease in bleeding. And probably some placebo effect. When you give something that you tell the patient, this will decrease your bleeding, it gives them some sense of a placebo effect. But in terms of the outcomes, the most useful outcome that I've seen with the evidence is it decreases bleeding, but not significantly.
Okay. So we should probably not encourage people with tranexamic acid then.
For
Same
us,
thing
sir,
upper
if it's
GI bleed
ano,
or lower GI
If it's
bleed.
significant bleeding,
it's
then you
massive.
should. Yeah, if it's massive, then you can use tranexam. But if it's just the office visit that I'm bleeding when I wipe my butt and there's blood on the tissue, then tranexamic acid might not be the medication to use. But if it's significant bleeding, then you should use it.
Huh?
Yeah. As I was saying, if it's massive lower GI bleeding, we give tranexamic acid. Although studies show that parang hindi sure kung may benefit. Pero
No
medyo
mortality
inano
benefits,
namin
yeah.
sa ano sir eh. If there, kanyari massive traumatic bleeding from trauma
Yeah.
or from massive bleeding during surgery where tranexamic does have benefit.
Okay.
So medyo correlated doon na if you're bleeding through the anus na substantial, maybe may benefit.
It might
in
help.
Tranex.
Okay.
Not just to control the bleeding, sir, more for the outcomes for the patient, less complications.
Great. I think this question is for Dr. Mac, and it's straight from Davao City. We often encounter patients in the clinic
Yes.
with recurrent hemorrhoids after hemorrhoidectomy.
Kasi they think that after hemorrhoidectomy, wala lang
Wala na,
hemorrhoids, di ba?
oh.
Yeah, that's a very good question.
So the question is there a limit on how many times can a person have hemorrhoidectomy?
It depends on
Ilang
the
beses ka
patient.
Yeah.
Saka on yung laki ng anal canal. What we do, we make sure that there's at least 1 centimeter skin bridge between each hemorrhoidectomy. If there's less, there's a very high chance na magsestenose. And that's why after hemorrhoidectomy, it's very important nga to advise on lifestyle modifications. Kasi we know nga, even if you remove this, if they're still constipated,
Yeah.
low fiber diet, low fluid intake, these hemorrhoids will recur. And as I think, siguro may experience yung nag-ask ng question with stenosis, which is really terrible for patients.
I agree. So, okay, there's a new question. Is there an indication on when to use a topical hemorrhoidal medicine versus an oral medication like thiazide and hesperidine? Maybe you can. I think we can.
Yeah, I mentioned it earlier that if you use topical, it's more for the anal pruritus and not for bleeding. And for the phlebotomics like Dioxel, we use it for bleeding most of the time. So I think that's the answer for that.
Okay. We have a question from Tacloban, right? Good evening po. How long do we need to use thiazide and hesperidine before we stop taking the medicine?
So I usually, my limit is usually a month. So 2 weeks, and then if it doesn't work, I continue it for 2 weeks. But after a month, if it doesn't work, and the patient really is taking a lot of fiber, taking a lot of water, lifestyle modifications, again, then you have to change gears and think of something else. But most of my patients, I could roughly guess 80%, actually all are improved with just 2 to 4 weeks of our medications and lifestyle modifications.
Okay. We have more questions. Okay. So there's also another question from Tacloban for Dr. Umlao. Do we routinely use proctosigmoidoscopy for all patients with hemorrhoids who are candidates for surgery for all ages? So let's start with that question.
We do routinely do proctosigmoidoscopy at the same setting of the hemorrhoidectomy. This is for run-of-the-mill patients who present with just bleeding and no other alarm symptoms. However, if the patient has family that's from hemorrhoid itself, we do recommend like flexible sigmoidoscopy or a colonoscopy prior to the hemorrhoidectomy.
So you would refer it to your friendly gastroenterologist.
Yes.
Okay. Next question also for Dr. Mac. You also mentioned surgical treatment can cause bothersome post-operative pain. In your practice, does band ligation offer less post-operative pain or regular post-op hot sits bath will do?
Definitely. Definitely, band ligation is much, much less painful than surgical excision. That's why if you notice colorectal surgeons, we don't like doing hemorrhoidectomy only if it's indicated because the post-op pain, it's really bothersome to the patients. And kami na rin na, kasi gabi-gabi yan Dok, ang sakit-sakit nung ano. So only if it's indicated, that's when we do the surgical excision or the excisional hemorrhoidectomy. Now, for the next question, will post-op hot sits bath do? Usually it's not enough. Hot sits bath helps. Number one, if the perianal area is painful, mahirap mag-wash eh. So usually pag may mucus doon, may sipon, it's very hard to clean. And the hot sits bath helps with hygiene. And next, if most of us will add some salt to the warm water, it helps decrease the edema from the hemorrhoids. But usually it's not enough. You'll need at least 2 more pain medications just to control the pain.
What pain medicines do you usually give?
I use an NSAID plus a tramadol and paracetamol combination. Usually that's enough. Some surgeons swear by opioids, but it's not readily available.
Okay. Have you noticed since the advent of phlebotomics that there has been a reduction of hemorrhoidal surgeries that you guys have been performing?
Yes, Doc Jun. Actually, most training programs kulang na sa
na
renal
sa-
surgeries.
Oh.
Hindi na kami makakredit. dahil-
Okay, so blame it on the
Oh,
phlebotomics then.
dioxyl na yan.
Okay, so I think moving on, more questions from our audience. It was mentioned that you will place the rubber band 2 centimeters above, I guess this is for Dr. Kitts, above the dentate line, so
It's
it will
for
be
Dr.
less
Mac.
painful. You would also recommend that we place our suture for ligation for hemorrhoidectomy at the same area, also to avoid post-op pain. And this is probably a surgeon,
Yeah.
asking, since you recommend 2 centimeters above the dentate line when you do rubber band, you recommend placing the sutures also the same distance when you do hemorrhoid surgery. Is that what you do in surgical
It's a different
practice?
technique.
Yeah, it's hard because some hemorrhoids do reach below the dentate line. And like for mixed hemorrhoids, and as much as you want to keep your sutures above the dentate line, sometimes the configuration of the hemorrhoid, you'll need to go below the dentate line. So if your patient is amenable to just placing the sutures above, go ahead, but not in all cases.
That's correct. Any more questions from our audience? How about in our venue? Anyone would like to ask more questions? Don't be shy. Okay, so I think this has been touched earlier, but I think we will just read the question once again. How long can Dioxel be given to patients with grade 2 to 3 patients who doesn't want surgery?
The difficult patients. So, again, 1 month lang, and then strict lifestyle modifications. But you should always recommend yung ligation or surgery in patients who really comply. But if they don't comply with lifestyle modifications, you go back to telling them to go increase their fiber in their diet, increase their fluid intake, because that's really is the basic of the treatment. Again, if it's 1 month, and then I actually give it a rest for 2 weeks, or even another month before I start again. I don't prolong it. I don't know with Mac.
Mac?
Usually, since we can offer surgery, parang kino-compare ko, sir, yung RBL with surgery. Yung surgery, masakit, under anesthesia. Pag in-explain mo kasi yung ganun, sir, usually they'll agree to a rubber band ligation para lang maiwasan yung surgical complications.
What equipment do you use as far as doing RBL? Since Dr. Kitts mentioned that you like to do the direct visualization approach using the endoscope. What type of technique are you using in your practice?
We use, sir, the metal parang gun na you load the rubber bands. When you graduate, sir, from a colorectal training program, yun yung graduation gift, sir.
They give it to you.
Rubber band ligator. Kasi wala ka pong pasyente sa start eh. Mag-rubber band ka na lang muna.
So this is kind of more on not really under direct visualization, more like palpation, right?
We use an anoscope, sir.
You use an anoscope with that, okay? Because the technique that you're discussing is really direct visualization.
Even with that, even with the Oregon, it's a direct visualization, which you actually open your anus and then you look. Sometimes you use a scope so you can see. But the difference now is some would ligate, some would suction, some would do rubber bands. So iba-iba lang yung pag-ligate. But it should be direct visualization because it's very hard to ligate without looking at the hemorrhoids, especially if you ligate the wrong part. Sisigaw talaga yung
And
pasyente
it has
mo.
to be above, like
Yes.
a few centimeters above the dentate line. Okay, we have a question here from Dr. Peck Eng Lim. Would you discuss the mechanism of diosmine and hesperidine in the treatment of hemorrhoids? And maybe, I thought Dr. Kitts discussed this briefly. Maybe you could give more details on
So
this.
in simple terms, Dr. Peking Lim, is that it improves the tone or the malleability of your blood vessels, specifically the venous blood vessels, in terms of their pliability. Because as we know, if the blood vessels get engorged, increase in pressure, if the veins are not pliable, they would easily burst. But if they're pliable, they just go big and then they slowly go back. Parang balloon. So that's what phlebotomics do. By increasing the permeability, decreasing the permeability, it adjusts with the pressures inside.
Okay, so I think we also have another question from Dr. Peck Eng Lim.
Giving too much high
As
fiber.
far as change in lifestyle, given too much high fiber can lead to constipation. Do you think giving stool softeners would be better than a high fiber diet? It's
Because high fiber, sometimes we forget that with high fiber, we should always tell our patients to drink lots of water. Because if you just take fiber, again, magko-constipate ka talaga. So again, it's just advising our patient to balance the intake of our fiber with increase in fluids. They always go hand in hand. Not just water, not just fiber. They always go together.
because fiber works by absorbing water,
Yes.
making the stool softer.
Yes.
So you can't just give fiber without any advice to
Yes.
increase fluid
Yeah.
intake. Do we have any more questions from our audience? Okay, this should be very interesting. Safety of Dioxel during pregnancy and breastfeeding.
Okay, it's if I remember right, category C siya. So actually, there's again with pregnant patients, there's not much evidence for it. I would not recommend giving Dioxel in pregnant patients because they're pregnant, and it's very common to have di ba, hemorrhoids in pregnant patients. So lifestyle modifications lang ako. Only if they really bleed massively, I would still not give Dioxel. I would recommend to a surgeon I do rubber band ligation. But these are special patients. In my opinion, because it's not parang it's unknown to give these in cases, especially in your first trimester. I would not give. Si Mac, ewan ko.
Have you done hemorrhoid surgery in pregnant women?
Oh, nice question.
Only if indicated,
Yeah.
which is severely thrombosed or necrotic hemorrhoids. Because the usual cases after their pregnancy, their hemorrhoids will
It
resolve
can
on their
induce
own.
pregnancy. So, pwede manganak when he does the
That's
surgery.
right, that's right. Okay. But you never had a case before during your training and practice?
We teach na almost never do hemorrhoidectomy on these pregnant
Yeah.
patients. Only in the extreme indications.
Okay. I think the next question is a little bit interesting. oranges and citrus contain hesperidine and diosmine.
Interesting.
Do you adjust the dosage of oral diosmine and hesperidine when patients are taking these citrus fruits? Do you have
I could
knowledge
not
on
answer
this?
that because I didn't know that oranges and citrus contains hesperidine. So probably you should, but there might the milligrams or the amount might be too small to have an effect. So I'm not sure about that one.
Maybe we could ask our audience here. Does anyone know that
How many milligrams of-
there's actually a diosmine and hesperidine in citrus fruits? Is anyone aware of such information? I don't think so. Okay. Next question is, do you still perform thrombectomy?
The old style treatment.
Matt?
Masyado atang bata, sir. Nakomenta na ako ng old style. For hemorrhoids, kasi we use the term thrombosed loosely. Actually, there are two types of thrombosed hemorrhoids. One is the thrombosed external hemorrhoid, which contains the blood clot, which definitely can treat with a thrombectomy. However, for the mixed and internal hemorrhoids, which are thrombosed, thrombectomy is not enough because the pathophysiology is not a blood clot causing the pain. It's just the edema is so severe that you can't drain the hemorrhoid, kaya siya magang-maga. So for those cases, excisional hemorrhoidectomy is still the preferred option.
Okay. I don't think we don't have any more questions. So before we end, I would like to get our final messages from our guest speakers. Let's start with Dr. Kitts.
Okay, thank you very much, everybody, for going here and meeting face to face. It's been a while, and I hope you learned a lot from these discussions. And I hope to see you soon again.
Dr. Mac.
Thank you, everyone. Thank you to the organizers for inviting me. Even as a surgeon, I think lately we've been doing less and less hemorrhoidectomies because we know the complications, the patients are miserable afterwards. So we're happy that we have this other drug that we can give to these patients aside from just lifestyle modifications.
Okay, thank you very much to our resource speakers, Dr. Kitts Dilusong, Dr. Mac Onlao. Thank you to Westmont for organizing this innovative and unique webinar. And most of all, I thank everyone in the audience here in our hotel. I think we have 27 venues all over the country, and we also have audience from their home watching us online. So thank you for tuning us, and they said there might be a part 2 in the future. So, and I'm very positive that a lot of us were able to take a lot of takeaways for our own clinical practice. So despite it being a pain in the butt, we can treat hemorrhoids. So this is Dr. June, and this is the Right Choice Podcast. Thank you. Be safe, everyone.